Thank you, Dr. Zeroba, for the introduction, and it's a pleasure to be here to kick things off, and hopefully we'll keep on time. I'll actually be starting us off today. Dr. Lott will join me about halfway through, and then I'll wrap up things at the end of this session. As far as disclosures, neither of us have any financial disclosures to mention. At the end of this presentation, we have several learning objectives. Essentially, we're going to walk through distinguishing shock types based upon clinical and hemodynamic parameters, talk about oxygen delivery, develop a monitoring plan for these patients, develop a treatment strategy, and then lastly, incorporate the Surviving Sepsis Campaign guidelines to develop a treatment plan for a patient with sepsis. The agenda for the presentation, as you can note, this is actually a little long session. So we'll first talk about the pathophysiology of shock syndromes, talk about some monitoring techniques and markers of perfusion, then use those to differentiate shock syndromes, develop resuscitation endpoints, and then jump into the shock states themselves, talking about hypovolemic, obstructive, vasodilatory, and distributive shock. Of note, cardiogenic shock will not be covered in this session. That will be covered by Dr. Eric Abel in the cardiac intensive care session. When we talk about sepsis, we'll start with the definitions in epidemiology and then the treatment pathway, talking about antimicrobials, initial resuscitation, fluids, pressors, and finish up with corticosteroids. I will mention that there are several topics that we won't have time to cover today during this presentation, but they are covered in the workbook, which you can find online. So jumping right into things, talking about shock. Shock is best described as acute circulatory failure. And so when I think about shock, I think really perfusion of the organs is inadequate. And it's best described as oxygen debt, meaning there is inadequate oxygen in those tissues. When we think about characteristics of shock, we often think of hypotension, but that may not be the only marker of the patient being hypoperfused. And so we may use a bedside exam to tell us if the patient is hypoperfused with these windows of perfusion. So a patient may have altered mental status, or the patient may have mottled skin or poor capillary refill, or the patient may have inadequate urine output as true signs of inadequate end organ perfusion. When we talk about the pathophysiology and the physiology of the circulatory system, we often talk about this alphabet soup that you see on the left that you're very familiar with, I'm sure. But for me, I like to actually break this down into very simple things. When I think about a patient's blood pressure being low, it's either a problem with the patient's cardiac output or a problem with the systemic vascular resistance. Looking further into the cardiac output, the two main components of that are heart rate and stroke volume. And the stroke volume has three main components. The first of which is preload, which is ventricular and diastolic volume, and it has a proportional relationship with stroke volume. The patient's intrinsic contractility also determines stroke volume. So think of this as a patient with a large myocardial infarction may have low intrinsic contractility. That also, again, proportional relationship with stroke volume. And then afterload being raised will actually have an inverse relationship with stroke volume. And so this is actually most described as the systemic vascular resistance. And so you actually have a nice circular tree here where if systemic vascular resistance is high, cardiac output is low, and those are generally thought of as inverses of each other. When we think about oxygen delivery, we usually think of these equations, and those of you who have been in practice are probably having PTSD right now, calculating out oxygen delivery and oxygen consumption. But when I think of this, I like to simplify things for my simple mind. I like to think that oxygen delivery, or DO2 here, the two main components are cardiac output and the content of oxygen within the blood. The content of oxygen within the blood is most determined by hemoglobin and the saturation of that hemoglobin. And so really the three main determinants of oxygen delivery are cardiac output, hemoglobin, and the saturation of that hemoglobin. You can use this equation, though, to go a little bit further, and you can estimate oxygen consumption, use the arterial-venous oxygen content difference to actually calculate the cardiac output, and this is the Fick principle that you can use if you have all of these parameters available. What's clear, though, is when a patient has shock, oxygen delivery is prioritized to the vital organs, and so the brain and the heart actually are well perfused first, and other organs lack perfusion. We usually think about monitoring these patients with invasive monitoring devices. We think about central venous catheters, pulmonary artery catheters, and really there's a lot of debate about which of these you should use, with central venous catheters being more favorable than pulmonary artery catheters. But even these days, central venous catheters are falling out of favor. One of the advantages of that central venous catheter is that it's easier and safer to insert than a pulmonary artery catheter, and you can actually get venous oximetry values from this catheter even continuously. One of the limitations with this catheter, though, is we often use CVP as a marker of preload, but at least in shock states, CVP shouldn't be utilized to predict fluid responsiveness, which we'll talk about in a little bit. The pulmonary artery catheter really has fallen out of favor in most ICUs. Many cardiac and cardiac surgery ICUs still use this catheter. At least the clinicians at our site think that they can interpret the numbers better than anybody else in the world, and probably the same for many other sites, don't believing the data that are out there about pulmonary artery catheters. One of the things to at least mention about pulmonary artery catheters when you're thinking about estimating oxygen consumption is that it's truly that. In most centers, you just estimate oxygen consumption. You don't directly measure oxygen consumption, and thus whatever calculation you have for cardiac output is dependent upon that oxygen consumption estimate, and that estimate may be far off in some shock states. In particular, septic shock, your oxygen consumption is vastly underestimated. Because of these invasive devices having flaws, a lot of centers are moving more towards non-invasive monitors, such as arterial pulse pressure waveform analysis monitors. These have various brand names, the Flow Tracker, Vigileo, Pico, or Lidco. At our site, we actually use the Flow Track, but it's also falling a little bit out of favor for a couple of reasons. The advantages of these devices are that you may actually have cardiac output measured or calculated without using a pulmonary artery catheter, just from the area under the curve of the pulse contour. You can also have some dynamic markers of fluid responsiveness, and this, I think, is where most centers are using these devices. You can actually have an assessment of stroke volume variation or pulse pressure variation. Some of the disadvantages of these devices, though, are based upon the accuracy. You have to have a good solid waveform on your arterial catheter. You can't have any valvular dysfunction. And if you have arrhythmias, particularly AFib, you can't use your SVV or PPV to actually predict fluid responsiveness. The other piece is that this device, at least if you're using it for fluid responsiveness, does rely on heart-lung interactions, and so your patients have to be on positive pressure mechanical ventilation to use these parameters to predict fluid responsiveness. And so with that in mind, some centers are using this even more instead of central venous catheters or pulmonary artery catheters. The one thing that I will mention is there has been no study that I'm aware of that has incorporated these devices or these parameters into a treatment algorithm that actually improves patient outcomes. Yes, they can better tell you if a patient is fluid responsive, but whether or not that actually leads to better patient outcomes is yet to be determined. When we think about using other markers of perfusion, I think of two broad categories. The first of those is lactate, the second of which is venous oximetry. Lactate is a great marker because it's non-invasive. It's usually produced under anaerobic conditions, and concentrations that are above 2 should be further evaluated. That doesn't necessarily mean act upon, but further evaluated. And like any concentration, this value is elevated when the production exceeds clearance. And I would love to tell you that lactate is the holy grail of perfusion, but we know that it's not. Even though an elevated lactate concentration can correspond to tissue hypoxia, it may also correspond to impaired clearance if your patient has acute or chronic liver failure, for example. Or it may also be produced through beta-2 stimulation and aerobic glycolysis, such as with epinephrine. Or even further, you may have impaired oxidative phosphorylation, such as with propofol-related infusion syndrome. And so an elevated lactate doesn't only mean that your patient is hypoperfused. So again, you have to take it into context. Another marker of perfusion that we commonly use at the bedside is venous oximetry, whether that be mixed venous or saturation of venous oxygen or central venous oxygen saturation. And really, these reflect tissue oxygen extraction. Again, I like to simplify things with a simple cartoon here. The heart supplies the tissues with blood through the arteries, and the blood comes back to the heart through the veins. The oxygen is delivered through the oxygen delivery with the saturation of hemoglobin nearly 100% on the arterial side. The tissues extract some of that oxygen, roughly at an extraction ratio of about 25%. And then the saturation of hemoglobin that returns back to the heart has a saturation of about 75%. And so if we think about that venous oxygen saturation, we can think that SvO2 approximates 1 minus the extraction ratio. But if you have a patient that has inadequate oxygen delivery, the tissues will increase their extraction ratio, such that a low SvO2 will result. And so as long as your hemoglobin and your oxygen saturation are the same, a low SvO2 corresponds to a low cardiac output, thinking back to our oxygen delivery equation there. And so really a lot of folks are using SvO2 or even SCVO2 as surrogates for cardiac output, and thus not needing to put a pulmonary artery catheter in for that patient. A lot of folks get bent out of shape about SCVO2 and SVO2 not being the exact same, and I would agree with that. They're not, but they do correlate, meaning that if your SCVO2 is low, your SVO2 is also going to be low. And so they can often be used interchangeably, at least for diagnosing shock states, but they cannot be used interchangeably, such as plugging them into your Fick equation and calculating cardiac output. Another common mistake I see at the bedside is folks placing a femoral central venous catheter and using that venous oxygen saturation to predict SCVO2. It actually cannot be used. You need to have a line that's in the thorax, so either a subclavian or IJ line, to actually use an SCVO2 for these purposes of markers of perfusion. And I think most importantly with these markers of venous oximetry is they really have to be interpreted in context. A patient may be walking around with end-stage heart failure with an SCVO2 or SVO2 in the 40s or low 50%. That doesn't mean that that patient needs to have an intervention to actually augment their cardiac output. And so you have to interpret this in the setting of other markers of end organ hypoperfusion or an elevated lactate concentration. Which brings us to our first case. Excuse me. This is a 77-year-old male who presents with lightheadedness and fatigue. He has a history of hypertension, asthma, and GERD. He has had increasing melena over the past 24 hours. You can see his blood pressure and heart rate there with a respiratory rate and temperature. His white count is 10, his hemoglobin is 6.6, platelets 180,000. So which value most contributes to this patient's compromised oxygen delivery? So using your audience response system there, answer A, B, C, or D. Okay, good. So it looks like the majority of you responded response number 2, or B, that the patient's reduced hemoglobin most corresponds to his inadequate oxygen delivery. In this case, you may have thought, oh, the tachycardia may have compromised oxygen delivery. Usually tachycardia improves oxygen delivery because it increased heart rate and increased cardiac output. But again, if you have a malignant arrhythmia, you may actually drop oxygen delivery, so be aware of that. Your patients with AFib may actually have compromised oxygen delivery as well. When I think about using these devices to differentiate shock states, this is a common figure that you've probably seen before, using arrows up and down to correspond to each of these shock states. And typically, we use parameters from the pulmonary artery catheter just to conceptualize what is going on in these shock states, but recognize that in practice, most of the time, you don't actually have these parameters. This is more so just to understand what's going on. Again, in practice, you may not have your cardiac output, but you may have an SCVO2 to use as a surrogate, or you may have an echocardiogram to actually tell you how the LV is functioning to correspond to cardiac output. You may not have an SVR that you've actually calculated, but often you can use your skin exam, whether the patient is cold or warm, to correspond to elevated or low SVR. When I think about hypovolemic shock, the main problem here is low preload, and so your CVP and wedge pressure are going to be low. In cardiogenic shock, the main problem is cardiac output being the problem. Obstructive shock is an interesting one because in a lot of ways it does look like cardiogenic shock and the arrows correspond. But really obstructive shock can be separated from cardiogenic shock in a couple of different ways. The first is one subtype being impaired diastolic filling of obstructive shock. Think of examples here as cardiac tamponade or tension pneumothorax. Or you may actually have impaired systolic contraction that is extracardiac. So this isn't an intrinsic problem with the cardiac muscle. It's actually a problem outside of the heart. And so the example that I think of here would be massive pulmonary embolism that leads to a low cardiac output. If you're asked on the board exam to actually differentiate between these two subtypes of obstructive shock, the way that you can do that is actually looking at the wedge pressure if you have a pulmonary artery catheter in place, where if the patient has impaired diastolic filling, they actually have elevated wedge pressure and equalization of pressures across the CVP, wedge, and PA diastolic. But impaired systolic contraction, you actually have a low or a normal wedge pressure. Last shock state that we'll talk about differentiating would be vasodilatory. And I think that this one is also confusing because the arrows can go a lot of different ways depending upon where you are in your stage of vasodilatory shock, particularly septic shock. But when I think about vasodilatory shock, I think, again, the hallmark here is low SVR or low afterload. And before you put any fluid into those patients, they have profound vasodilation, inadequate preload due to venous pooling, as well as loss of intravascular contents that leads to low cardiac output. After you resuscitate those patients with fluid, then you actually have elevated preload, elevated cardiac output in most patients, and still a low afterload. And so I think that using these devices and other markers of perfusion can help you understand which type of shock state your patient has so you can develop a treatment regimen. So we'll move on to case number 2 and try to apply what we just learned. So this is a 77-year-old male who has cirrhosis who presents with hematemesis. His hemoglobin was 9.2 by history. On presentation, it was 7.3, and you can see the patient is quite hypotensive. He was given 2 liters of lactated ringers and 2 units of packed red blood cells, and his hemoglobin is now 9.1. The team wasn't quite sure what kind of shock the patient had, so they placed a pulmonary artery catheter, and you have these values available. So a CVP of 8, a wedge of 14, cardiac output is 7.4, and the patient remains hypotensive. With which of these shock states are the patient's hemodynamic parameters most consistent? So again, if you answer 1, 2, 3, see what we thought. Oh, look at this. Nice even mix between hypovolemic and vasodilatory. For those that answered hypovolemic, I would agree that his presentation sounds a lot like hypovolemic, but if we actually look at the pulmonary artery catheter numbers, his numbers are actually more consistent with vasodilatory shock. You can see here he actually has normal to high CVP and wedge and an elevated cardiac output. And so if you pulled out those equations and actually calculated the patient's SVR is actually quite low. So the numbers are more consistent with vasodilatory, but again, the presentation is hypovolemic. And I think one of the key hallmarks here as well is that his hemoglobin has been restored and his preload markers are again adequate. I think that this is an interesting case and actually was drawn from a case I saw in practice. This was a patient who actually had spontaneous bacterial peritonitis as a complication of his hematemesis with his cirrhosis and actually had septic shock as his ongoing hypoperfusion. When we think about setting up goals of therapy for these patients, I generally think of 4 main categories for resuscitation endpoints. The first is we want to have an adequate blood pressure. Usually we think of mean arterial pressure in these cases because mean arterial pressure is the bulkhead perfusion pressure for the tissues. Generally a MAP above 65 is the target. Some shock states actually call for a systolic as the target, but most use MAP. In the end, you really want adequate end organ perfusion for these patients. And so if your patient had altered mental status, you want that to be resolved, or you want adequate urine output, generally above 0.5 mLs per kilo per hour. What's challenging, though, is that often these markers of end organ perfusion are difficult to assess. For example, if your patient is intubated, mechanically ventilated, and sedated, you're not able to assess their mental status. Or if your patient has renal insufficiency, their urine output may be inadequate from end-stage renal failure. The second 2 points, such as lack of fluid responsiveness and adequate oxygen delivery, we'll actually dive into deeper here on these next 2 slides. We know that fluids are an important component of shock resuscitation, and that's because we want to give fluids to actually restore effective preload to increase the stroke volume and thus improve cardiac output and increase oxygen delivery. But if you give too much fluids, you actually have detrimental effects. And we're not talking about peripheral edema and the Stay Puft Marshmallow Man here. What we're actually worried about is pulmonary edema. And these patients may actually become very hypoxemic because of so-called over-resuscitation. And so it's probably best to decide, will my patient actually respond to this fluid or not? And when we think about response, typically in the literature, this is defined as a 10 to 15% increase in cardiac output when you give a fluid challenge to a patient. Historically, we've used what are called static markers to determine this predictiveness, and we use CVP or wedge pressure. But these markers actually only have about 50% prediction on whether or not your patient will respond to a fluid challenge. These more dynamic markers, such as stroke volume variation, pulse pressure variation, actually have about 90% predictive ability. And so if you're really stuck up against the wall to decide, should I give fluids or not give fluids, don't rely on your CVP or wedge. Try to use one of these markers to make that determination. Again, as we talked about before, we can't use these markers, though, when your patients have arrhythmias or in patients who are not mechanically ventilated. If you want to use a dynamic marker of fluid responsiveness in a non-intubated patient, the passive leg raising test is an option. But keep in mind, to determine response to that test, you can't use blood pressure. You actually have to have a marker of cardiac output. And so you probably have to have one of these non-invasive devices to be able to tell you, did the patient's cardiac output go up by 10 to 15% when you do the passive leg raising test. Again, back to using venous oximetry and adequate oxygen delivery as a resuscitation endpoint. I think we've learned over time in a study about 20 years ago that we shouldn't target supranormal oxygen delivery parameters. We shouldn't artificially raise these values. And really, when we think about oxygen delivery, I don't tend to think about this as a cardiac output number of 4, 5, 6, whatever number you have in mind as being the right number. I tend to think of this as, is cardiac output adequate or inadequate? And if you determine that cardiac output is adequate, then it doesn't really matter what the number is. You can use your concomitant assessments to determine if cardiac output is inadequate. Again, end organ perfusion, lactate, with your other parameters. If you determine that it's inadequate, then use your markers of oxygen delivery to actually have targets. So if your patient is fluid responsive, give them fluids to improve cardiac output, give them blood if the hemoglobin is less than 7, or even inotropes in these cases if your patient has inadequate cardiac output. It's probably more important, though, to target this early oxygen delivery in the early parts of shock as opposed to later parts of shock. To optimize oxygen delivery 24 hours or later hasn't been shown to actually improve outcomes. We can also use lactate as one of our resuscitation markers, and lactate clearance and normalization is a hot topic, at least within the sepsis literature. When you decrease the patient's lactate, it suggests that you have improved global perfusion, and by improving oxygen delivery, you may improve lactate concentrations. The advantage, as I mentioned before, is that it doesn't require invasive monitoring, doesn't even require an arterial stick. Venous lactate and arterial lactate can be used pretty much interchangeably, and as I mentioned before, mostly it's used in septic shock patients. Moving on to case number 3. The previous patient that we talked about developed hypoxemia requiring intubation and mechanical ventilation. His FiO2 was elevated all the way to 90% because of hypoxemia, so he was sedated and started on atracurium infusion. He remained hypotensive with a low urine output. And so which of these values best predicts if this patient will be fluid responsive? Okay, great. You're paying attention. SVV above 16% will best predict fluid responsiveness in this patient. Some of you may have thought, oh, the patient's blood pressure is low. Again, remember, blood pressure corresponds to a lot of different values, including cardiac output and SVR, so that doesn't necessarily tell you that the patient will respond to fluids. I think this patient scenario is actually the ideal scenario to use one of these dynamic markers of fluid responsiveness. Not only is the patient sedated and paralyzed when these values are actually most validated, but also this patient is extremely hypoxemic. And so this patient has a low margin for error to give more fluid when your patient may not actually be fluid responsive. Jumping into the agents that we use to treat shock, typically we use fluids first in these patients, and typically crystalloids are first line. I know you're all familiar with the SAFE study that in mixed shock states found similar outcomes between saline and 4% albumin. There's a lot of interest in using fluids with lower chloride content, and actually a very nice meta-analysis in randomized controlled studies that recently discussed this piece. The reason that chloride is thought to be harmful is that it may actually cause renal arterial vasoconstriction and thus decrease glomerular filtration rate. And also it may lower the strong ion difference. And so this is typically described as hyperchloremic metabolic acidosis. Despite a lot of retrospective studies suggesting that using chloride-rich fluids will be harmful, actually there's a large randomized trial that actually found no difference in randomizing patients to low or high chloride content fluids. Now, this study does have some flaws to it, so I don't think this is the end of the study, or the end of the discussion, but it's at least one inkling that maybe the chloride piece isn't as important as what we thought maybe even a year ago. I think that most of you are well aware of the FDA's black box warning about hydroxyethyl starches, that they shouldn't be used in the ICU for resuscitation. When thinking about vasoactives, I know you're all quite familiar with the pharmacology of vasopressors. We should use vasopressors really in patients who remain hypotensive after fluid resuscitation, but I think that it's also important to remember that perfusion is important in these patients, and so even if you're still giving fluids to a patient and they're not responding to that fluids, you may need to start pressors at the same time as you continue to give fluids and determine if your patient will still be fluid responsive. The pharmacology here, again, I know that this audience knows this well. A couple of the things that I will point out, though, is that norepinephrine maintains cardiac output despite a profound increase in systemic vascular resistance, and that's different than phenylephrine, which may actually drop cardiac output because it doesn't augment beta receptors. Norepinephrine, dopamine, and epinephrine all have increasing alpha activity as you increase the dose. So at lower doses, you'll see some of those beta effects, and as you get to higher doses, you see a lot more alpha effects. In my mind, I separate vasopressin from all of these. Some think of this as endocrine replacement therapy, some think of this as a pressor, but again, it behaves very similarly to phenylephrine. The only difference is that studies have actually shown that it does not drop cardiac output. I know you're all familiar with the SOAP2 study, which randomized patients to dopamine versus norepinephrine in mixed shock states. The study did not find a difference between the two agents in the primary efficacy outcome of 28-day mortality, but there were important safety differences between the two agents. The first of which was that dopamine wasn't as effective as a vasopressor, and so the patients more often needed to have open-label norepinephrine, and more importantly, patients more frequently developed arrhythmias when they were randomized to dopamine compared to norepi. But which pressor you pick really depends upon the shock state, the pathophysiology of that shock state, where your patient is in their resuscitation course, and even your therapeutic goal. Which brings us to case number 5. This is a patient who was presented to the surgical ICU with shock after an appendectomy that was complicated by perforation in the operating room. The patient was given 2 liters of lactated ringers, 1 liter of 5% albumin, 2 liters of 6% hydroxyethyl starch in the OR. Again, a case taken from our practice. This is what we do. The patient's MAP was low. The lactate is 5.2 on 14 mics per minute of norepi, and the patient's SCVO2 is 61%. A bedside echo in the ICU showed large ventricles with poor contractility. So which of the following actions is best for this patient? All right, let's see what we came up with. Oh, that's interesting. We have a lot of different answers here. I can tell you for sure, if this was a patient in the ICU where I practice, the patient would be started on vasopressin because that's what we do. Every shock stay is the same. However, in this patient's case, you actually have evidence of low cardiac output. And so the patient's SCVO2 is low, and the echo shows that the patient has inadequate ventricular function. And so here you probably want an agent that has some inotropic properties. And so those of you who answered, oh, I just want to increase the norepi, that may be a reasonable answer, but you probably need more cardiac output for this patient. And so this may be actually one of the very rare scenarios where starting epinephrine might make a lot of sense. So I'll pause there, and Dr. Allott will take us through the shock states, and I'll be back.
Good morning, everybody. We're really excited about being able to present on this topic. This is definitely a topic that Seth and I are particularly interested in. This is a topic that both him and I have collaborated on in terms of research, and definitely a lot of opportunity for continued research and generation of knowledge within the critical care realm. Shock syndromes, to us at least, defines the epitome of critical care, and so focusing on this was really important to us. We have a fair amount of time, and so as Seth and I were deciding how to split up the lecture material, we thought it'd be best to give you 2 helpings of Seth and 1 helping of ESHOC, and hopefully everyone can benefit from that. I think one of the other comments that I wanted to make, that in particular to shock syndromes, is how much is still yet to be known. Whether it's the right sequence of interventions to make, or how to interpret different shock syndromes, or what are suitable resuscitation endpoints, you'll notice that over the course of the next few days here at Congress, as you attend different sessions, you will notice that hopefully a critical review of the literature will tell you that there isn't really high-level evidence for a lot of the things that we're still discussing, even in the year 2016. So this, for many of you in the audience, hopefully serves as an impetus to help go out and generate new knowledge, and we'll discuss what it is that we know here today. And hopefully over the course of the next patient cases, we'll also start guessing some of the different bands that they're playing, so we'll do that together. I'll start with hypovolemic shock. This is most commonly pardon me while I try to get this mouse oriented. This is most commonly attributed to traumatic sources of bleeding, but there are more common sources of bleeding in hypovolemic shock within more medical surgical ICUs, those being predominantly gastrointestinal bleeding, surgical bleeding, obstetrical bleeding, and pharmacological toxicity increasingly so. I know within our medical ICU where I practice, GI bleeding is the most common reason for admission to the medical ICU, even more so than sepsis or respiratory failure. So, and I'm sure this is probably reflected within your own practice settings as well. It's estimated that on an annual basis there are approximately 2 million deaths per year due to hypovolemic shock due to trauma. ATLS and the American College of Surgeons put together a nice categorization and classification scheme of the different categories of hypovolemic shock. You'll notice first is class 1. The different discriminators are what's really important here too, which one isn't just purely the amount of blood volume loss, but it's also the effects on large body systems and organ systems that they end up having. So for example, class 1 hypovolemic shock is partially due to a certain amount of blood loss, but also is reflected in an increasing heart rate, increasing respiratory rate, and urine output. decreasing and increasing levels of CNS obtundation. So you'll see over here with class 4, when you've lost close to about half of your total blood volume, you'll start seeing that there's significant tachycardia, significant tachypnea, reduced or developing oliguria, and then also CNS obtundation, usually resulting in lethargy on clinical exam. Which leads us to self-assessment question 7. You probably reflected similarly in many of your own medical centers. You have a 41-year-old male, especially with better weather, is out riding his motorcycle where there was an unfortunate accident. He presents to your medical center with rib, pelvis, and bilateral femur fractures. Vital signs at admission are 82/48. Tachycardia reflected with a heart rate of 125, respiratory with 34, and temperature of 35. And guess the band that they're going to bring up on the music, wherever you guys want. Oh. So, which is the appropriate class of hypovolemic shock according to ATLS? Is this class 1, class 2, class 3, or class 4? And who guessed Jack Johnson? Okay, all right. Perfect. You have class 3 being the predominant answer choice here. Again, when reflecting back on the different categorization schemes, you'll see that based off of the amount of blood loss, but also reflected in the blood pressure and the mentation, you'll see that this fits class 3 according to the ATLS. So upon presentation or upon development of hemorrhage, there's a multifactorial response from physiological response in terms of how the body deals with blood loss. First, immediately is the sympathetic response. You see a low pressure then develops and reacts with where the high pressure receptors are activated. You'll see a subsequent increase in heart rate and myocardial contractility and arterial tone. At the same time, you'll also see a parasympathetic response, which reduces the vagal tone but increases the heart rate. Normally presented in most cases with orthostatic hypotension in patient settings. There's also at the same time an intrinsic response which develops over the course of the next few hours to days even, where there's a redistribution of fluid into the vascular compartment, and then also a humoral response with the activation of the renin-angiotensin-aldosterone system. So resuscitation to hypovolemic shock is similar to endpoints which we've discussed already. The first thing that you want to do is identify and treat the bleeding cause if it's possible. You also want to begin resuscitating the patient. Guidelines will recommend using crystalloid over albumin or colloid volumes with an with a systolic target of roughly about 90 millimeters of mercury. Transfusion strategies are typically targeted to try to raise the hemoglobin to about 10 or hematocrit value of 30%, and try to maintain that in the setting. There was a recent trial that looked at the hemoglobin targets was specific to gastrointestinal bleeding, and it was found that 7 is suitable and non-inferior to a hemoglobin target of 10. And finally, vasopressors is a temporizing measure, primarily because you'll also have activation of your sympathetic and parasympathetic response. You only want to use these in the lieu of getting subsequent volume resuscitation. We'll move on to burn resuscitation. What's interesting to me is that after many years of burn injury and thermal injury, and some of that has evolved over the course of the last decade or two, especially with blast injuries and trauma in the combat setting, there's an increasing focus on research on how to, one, the physiological response, two, is what's the appropriate way to stage and deliver resuscitation for patients or soldiers out in the field. This has also been an increasing area of research for the Department of Defense, mainly because of their investment in the area. You'll notice that the first thing that happens physiologically is a third space resuscitation, or third spacing of volume into the peripheral space following fluid injury. This is quite significant and actually quite exaggerated in many settings. Fluid resuscitation, therefore, is needed to restore the intravascular volume, with the therapeutic goal being similar to what you've already seen before, a urine output of approximately 0.5 mils per kilo per hour, and a little bit more more robust in children, 1 ml per kilo per hour there. The most common formula that's used for resuscitation is the Parkland formula. There are a couple others that are out there, but you'll see this is usually the one that's used in most clinical settings and also recommended in clinical practice guidelines. Simply, it's 4 mils per kilo per total body, a percentage of total body surface area burn, and that's broken into the first 8 hours with the subsequent 16 hours. And so the patient will receive 2 mils per kilo per hour for the first 8 hour per percentage for the first 8 hours, and then you'll slow down the rate a little bit over the subsequent 16 hours. Which takes us to patient case 6. You have a 29-year-old male. He weighs approximately 85 kilos and is about 6 feet tall. Suffers a 40% total body surface area due to a fireworks accident to a lower extremity and to the buttocks. Which is the best option for resuscitation? Option choice A, option choice B, C, or D? Okay, so most people were able to calculate option choice B. This is a little bit difficult to do if you don't have a calculator, but hopefully most everybody had the chance to review or at least take a look at some of this before, or many of you came prepared with calculators on your own. You'll see when you actually calculate it out, the 4 mils per kilo per hour. So if you do 4 mils times 85, you'll come up with roughly about 340 milliliters there, times the 40% of total body surface area. And then when you break that out over 6 and 18 hours, you'll come up. It's not exactly 13 liters. It's a little bit more, a little bit less, but when it's approximate, and I think that's good enough here. What's challenging also in many of these settings is the management of coagulopathy. And this could be in combination with the thermal injury or the hypovolemic episode that you've experienced, or it could be independent of that in other settings itself, whether it's due to pharmacological issues or the pathophysiology of the overall shock syndrome. There's something that's called the lethal triad, which is a combination of hypothermia, hypocalcemia, and acidemia, and all of those will need to be corrected for the coagulation system to work properly. I think if you reflect back to a therapeutics class, you will probably remember there's a certain calcium is used as a cofactor to help promote the coagulation cascade, and the coagulation cascade works best when your body temperature is euthermic and your pH is within a normal appropriate range. It tends to go awry and tends not to function as well when you have severe deviations from normal in those areas. There was a recent study that looked at what's the appropriate component resuscitation strategy, 1-to-1-to-1 versus 2-to-1-to-1-to-1, or 2-to-1-to-1. And what ended up coming out was that a 1-to-1-to-1 resuscitation strategy was actually superior to a component strategy that was a little bit more aggressive in terms of amount of plasma that's being resuscitated. There are multiple treatment options pharmacologically for the treatment of bleeding. I think many of us have seen this in our clinical practice and have struggled with what's the appropriate way to use many of these agents within clinical practice, also with what's available in the clinical literature. Factor VII being probably available now for almost 15 years and something that we've all probably have gained sufficient clinical exposure with. Increasingly so in the course of the last 2 years, you will see experience with PCCs and tranexamic acid and alpha-aminocarboxylic acid have been around for quite a bit of time, but you'll see a resurgence with tranexamic acid, especially in the setting of trauma in the last few years. Recombinant factor 7A, which I'm sure many of you are familiar with, works multifactorially, primarily by activating tissue factor and factor 10 and factor 9. However, unfortunately, despite the amount of time that the drug has been on market, it's been predominantly studied in the treatment of hemophilia. So most of what you're using in the critical care setting has been off-label. Subsequently, there's been studies that have looked at the safety and efficacy in real-world practice data with off-label use, and unfortunately, there are significant safety concerns with an increase in arterial and venous thromboembolic events. You probably have noticed this within your own clinical settings, is that there's been a little bit of neutralization of the enthusiasm for factor VII over the course of the last 5 years. Hopefully you've noticed that at your sites. It's not used quite in the same volume or the same frequency as it has been, also because of the data that's been coming out, but partially also because of the other available therapeutic options now. PCCs are something that have come out in the market and have been available. You have predominantly 4 different types of PCC products. I'll focus on the 2 that most clinicians and pharmacists are familiar with, which are FIBA and Kcentra. The main difference between the 2, you see there isn't necessarily the components of the different factor products, though there is a little bit more factor VII in FIBA. It's the activated form of factor VII in FIBA, which is what discriminates that or distinguishes that from Kcentra. Kcentra is what was brought to market specifically for the treatment and reversal of warfarin-related hemorrhage bleeding. There is interest in wanting to use it similar to, or in exchange for FFP, predominantly because of the significantly less volume that's associated with giving it. However, unfortunately, there isn't a lot of data to support that to this point. Kcentra has only been studied in warfarin-related bleeding, and FIBA has been studied in a couple different areas, though predominantly in hemophilia is where you see that. Within trauma, there was probably the largest trial of critical care patients that I've come across, 20,000 patients with trauma, which is the CRASH-2 study. This was done over 40 countries, and when you look at the actual trial methodology, it's really impressive to notice how much organization was required for a study like this. 1, in terms of randomization, 2, in terms of resources, and in terms of deploying and making the drug available within the within the trauma setting, which is not easy. And when you're trying to spread this across 40 different countries, it's even more impressive in terms of how the study was actually able to get done. The study was broken down into roughly about 10,000 patients per arm, tranexamic acid versus placebo. For patients that were randomized to tranexamic acid, they received 1 gram over 10 minutes with a 1 gram infusion over the subsequent 8 hours. All-cause mortality was significant in favor of tranexamic acid. There's a mortality benefit or survival benefit for patients that receive tranexamic acid, though you notice that the absolute difference is only 1.5%. So it's not really easy to find that difference. And had the trial been underpowered or a smaller sample size, you likely wouldn't have noticed that. You also notice that the death due to bleeding was also in favor of tranexamic acid. I'll make a quick comment about this is, what's interesting to me is that there is an enthusiasm for using other recombinant drug products for the treatment of bleeding, but you haven't seen that same sort of enthusiasm spread over to tranexamic acid for other types of bleeding disorders that you've noticed with perhaps factor VII or Kcentra. And so just a little bit of a side in terms of sometimes the bias that clinicians will bring in terms of how to apply a drug therapy. This is a topic that's becoming increasingly relevant to many of us as clinicians. You'll see, my guess is over the course of the next 10 years, you'll see a declining use of warfarin, which means an increasing use in other types of drugs or all anticoagulants, predominantly because of their safety, also because of the ease of monitoring and therapy for patients. You see a breakdown here of the different types of drug therapies that are available. Warfarin still is the leader in terms of the drugs that are the frequency of indications for use, though it's not really easy to use, and it's been around for 50 years. Despite it being around for 50 years, we're just now getting to the point of trying to apply it with pharmacogenomic testing and how to actually make it more patient-specific. You notice the other 4 new options, dabigatran, apixaban, rivaroxaban, and most recently edoxaban. What they all have in common is their peak action is roughly about 2 hours, and that they're all renally eliminated to some extent, dabigatran being the most, edoxaban and rivaroxaban also being there. What this applies to then is how do you handle this when patients present to your clinical practice setting, either from hemorrhage due to just regular use of the drug, or because that there's been a subsequent organ dysfunction that's developed over time, leading to overaccumulation of these drugs in the system. With regards to warfarin reversal, you see the listed suggested Kcentra dosing here. The approval trial only looked at patients with an INR greater than 2 to 4. If I can get a quick show of hands, within your practice settings, how many of you have the drug approved for within your practice site for an INR less than 2? About a third of applicants. I know at our site we also allow it for an INR greater than 1.4. The challenge is what dose do you give for that range of 1.4 to 2, which hasn't been studied, and I'll let that sort of reside within your individual practice setting, because there isn't a lot of data to be able to drive that decision. It's the indications for use are greater than between 2 to or greater than 2, with a subsequent decrease in hemoglobin of greater than 2 within 24 hours, and also bleeding in the critical site. You see the dose is dependent on the INR range and also on the patient weight, with the maximum dose being 2,500, 3,500, or 5,000 units per INR range. What's interesting, though, is because the drug is derived from plasma, the actual amount of factor 9 units per vial isn't the same, and so therefore, if you're trying to calculate it out the dose, you have to actually look at the vial, at each vial, and then actually calculate out the dose and add it all up, which isn't an easy process in terms of drug delivery, drug preparation, and then drug delivery. Some estimates have put drug delivery and drug preparation and delivery at roughly about 30 minutes, which makes it challenging in the setting of a patient who's actively bleeding. So, treatment of bleeding due to the novel oral anticoagulants is becoming a challenging problem, mainly because of the increasing amount of use of those drugs. For those patients that present in less than 2 hours, which is almost never, it's recommended that you use activated charcoal. You can actually try to eliminate some of the drug from their duodenal tract. Most recently approved to market is Praxpine or dariusuzumab for the reversal of dabigatran. My guess is that many of you are starting to implement that within your health systems. Hemodialysis is also a suitable treatment option because of the fact that the drug is so heavily renally eliminated, but that's also dependent on the clinical status of the patient themselves. There is proposed reversal of factor 7 and PCCs with these novel oral anticoagulants. However, when looking at actual blood lab markers, the response is variable. You don't see a consistent response with any of the drugs, and so therefore the data is not robust in terms of which of these drugs you would use. There are additional drugs in development. I'm sure that many of you have seen the most recent publication with Adexanet for apixaban and rivaroxaban reversal. That should be getting reviewed here by the FDA within the next year. And there's also one other investigational agent that's being investigated. What's sufficient, though, to say is that in general, it's challenging. There is no best way at this point other than using a target-specific drug for reversal of these agents. Trying to give a recommendation for which dose of PCC or what dose of factor 7 to give, the data just isn't there at this point. So it leads us to patient case 7. We have a 67-year-old male who's out hunting with his friends. He gets shot in the buttocks during wild deer hunting. He receives a 500 milliliter lactated ringers and transfer, and you see his vitals listed there. He's drowsy and slightly incoherent following a dose of morphine 2 milligrams. So which is the best resuscitative strategy for this patient? Option A, continue lactated ringers with a urine output target. Transfuse blood components. Transfuse blood components and also give additional fluid, or just increase the amount of crystalloid that's being given. Okay, so In Excess was a difficult selection to follow. I'm sure many of you were wanting to get up and dance. So many of you guessed option 4. which is the appropriate answer here. You want to not only give increased amounts of crystalloid for this patient, but you also want to select the appropriate resuscitation endpoint, which is a urine output greater than 0.5 mils per kilo per hour with a target systolic pressure greater than 90. Moving on to obstructive shock, as Dr. Bauer excellently touched on earlier in this session, it's predominantly due to either one of two reasons. It can be due to extracardiac obstruction of flow, which is usually the most common reason. You see this in the setting of massive or submassive PE, which has progressed on to massive pulmonary embolism. You can also have impaired diastolic filling due to cardiac tamponade or pericardial infusion or tension pneumothorax. What you'll see is an inhibition in venous return and reduced right ventricular preload. This is probably one of the more challenging shock syndromes to manage for two reasons. One is because there isn't really a lot of drug therapy options that are available. Two is because it progresses so quickly and so rapidly that if it's not managed within an appropriate time setting, either with mechanical deconstruction or reversal, that it just progressively worsens and leads to fatal outcomes. The treatments are predominantly mechanical. Fluids are recommended, though this is really challenging, especially in the setting of right ventricular preload. You want to give the right amount of fluid, but not too much fluid such that a failing right ventricle can't support the left ventricle. And vasopressors to maintain perfusion pressure. Again, this is more of a salvage therapy and really not recommended in majority of settings. What you see here in a physiological standpoint is it begins with right ventricular pressure overload, which progresses to reduced cardiac output on the right ventricle, which then impedes on the left ventricle, leading to reduced cardiac output overall. You see systemic hypotension and reduced right ventricular tissue perfusion, leading to ischemia and reduced right ventricular contractility. It's a really vicious cycle that rapidly progresses and can happen over the course of minutes in some of the cases. In terms of impaired systolic contraction, what is recommended, and you'll see this predominantly in settings of pulmonary hypertension, is most require diuresis. Again, the touch point between what's the right amount of diuresis and what's the right amount of fluid that's needed in the right ventricle is really difficult to manage and can be patient-specific. For PE, you can give fluids. It's recommended, though you probably just want to go ahead and start treating the PE that's happened. Vasopressors are recommended, though typically it's norepinephrine. You want contraction within the pulmonary circuit itself, but also to support cardiac output over time. There isn't a lot of evidence. There is a couple of smaller studies that are going on to determine what's the appropriate vasopressor in a setting like this. Inotropes are likely more effective, but again, there isn't robust data to support this, and you can recommend disease-specific therapies. I'll focus more on pulmonary embolism here because that's usually the predominant cause of obstructive shock. In large studies, no mortality benefit has been found in unselected patients, though this is, like most shock syndromes, probably the devil is in the details, which is the appropriate patient to receive thrombolytic therapy, and then also what stage of progression of pulmonary embolism is the appropriate time to intervene and provide the therapy itself. It's recommended clearly for massive pulmonary embolism, especially in patients that are hypotensive, but the benefit of your therapy is probably most likely to be found prior to cardiac arrest. I think many of you probably have seen this within your own medical centers. We see this quite a bit in a teaching center. You have a prolonged cardiac arrest, and the house staff will feel it's appropriate, suitable option to provide a thrombolytic therapy at that point. Unfortunately, the patient's already been suffering cardiac arrest for 10 or 15 minutes, and therefore your benefit is going to be neutralized more by the harm, which is in that case likely going to be bleeding. It is controversial for submassive PE, and I think, again, this is primarily due to the timing of intervention. When you give therapy in something that's going to be rapidly progressing, and when's the appropriate time to intervene? Do you intervene as soon as submassive PE is identified, or do you intervene as the time as it progresses to massive PE? And also, the mortality from this is so small that you need such a large trial to be able to find a difference, and we'll get into that here in a second. You also have to consider the contraindication to thrombolytic administration. Thrombolytics are a high-risk medicine. They don't come without harm, and we'll also describe here in a second what some of that harm is. This is data from the PITHO study, which looked at tenecteplase versus placebo. This was done as a multi-center study which expanded on the original alteplase study for submassive PE, which was published in New England Journal of Medicine back in the early 2000s. This was then done as a larger study looking at tenecteplase. Tenecteplase versus alteplase, I think many of you are aware, tenecteplase being more tissue specific would provide proposed pharmacological benefit in a setting where you have a pulmonary embolism. What's interesting to see is you see a sort of a contradiction in terms of risk versus benefit. You notice that there is a benefit in terms of survival to giving tenecteplase, but then it's also balanced with the amount of harm. And again, I think this is what you don't notice here, and what some of the data that wasn't collected was the time to administration, or the timing and the progression from initial presentation to when the drug was administered, which would be really interesting. And I think ultimately what many of us as clinicians walked away from after reading the study was, you give it. I think many of you will still keep giving it, especially in the right setting and a patient's decompensating from massive PE. But you will continue to keep evaluating for those patients that may not benefit and actually suffer harm from it. Those that have received therapy, those are receiving other anticoagulant therapy, and also those that may have had a recent intervention are those that are most likely to have harm or experience harm. Next is our patient case. Is a 48-year-old female weighing 75 kilos who presents with a subsegmental pulmonary embolism. On echo, there is no right ventricular dilation or dysfunction. She is tachycardic, slightly hypotensive, troponin of 0.06 with a BNP of 60. In addition to parenteral anticoagulation, which is the best treatment option for her? Is it A, tenecteplase, B, alteplase, administered over 2 hours? Is it alteplase as a 50 milligram bolus? Or is it no thrombolytic therapy at all? Okay. Great. So most everybody guessed that it's no thrombolytic therapy at all, mainly because the patient doesn't have right ventricular compromise. There is this is still in the progression where a patient has pulmonary embolism but hasn't even quite progressed to submassive PE or massive PE at this point. So providing thrombolytic or providing thrombolytic therapy at this point may not provide the same benefit versus probably increased harm. Moving on to vasodilatory shock and distributive shock, this is primarily described by reduction in systemic vascular resistance. Most commonly seen in sepsis and septic shock, though also seen with forms of advanced cirrhosis, and possibly you can group in anaphylactic shock also within this group of shock syndromes. This is primarily due to a failure of the smooth muscle in terms of contraction. So how is it that you maintain a tight system to promote perfusion to the end organs while also promoting oxygen delivery at the same time? Over time, as it progresses, you'll see a reduction in preload. The first thing in addressing vasodilatory shock is treating the underlying cause, providing crystalloids when appropriate. In terms of vasopressor choices, norepinephrine's usually used for neurogenic shock, though there isn't high-level evidence to support one vasopressor choice over another in this setting. An immune-mediated vasodilatory shock, again, predominantly due to anaphylaxis. Epinephrine is conventionally used, where, again, there isn't great high-level evidence in terms of one agent versus another. The role of adjunctive agents is controversial, both in terms of anaphylactic shock and then also, as Dr. Bauer will get into here in a bit, with septic shock. And with that, I will hand it back over to Dr. Bauer.
The tall guy kept moving the microphone up, so I'll put it back down. Those of you looking ahead in the slides are probably saying, oh boy, we're going to cover all of this sepsis in 25 minutes. I know that you as practitioners are well familiar with this topic, so I'll try to go quickly through some pieces and touch on some of the more controversial pieces. We'll start off, though, with a patient case. This is a patient who presents to the ED with shortness of breath and productive cough. A chest radiograph shows a left lower lobe pneumonia. You can see the patient's vitals are here. Blood pressure systolic of 115, heart rate above 100, respiratory rate of 26, and febrile. Labs are also listed here: hemoglobin, white count, platelets, lactate, and serum creatinine. And so which of the following conditions best describes the patient's condition? And I'll show you the case again to make that determination. Okay. Looks like the majority of you answered severe sepsis, and I think that's the best answer here. The patient had some end organ dysfunction, as well as a systemic inflammatory response with an infection. The patient's lactate was elevated and platelets were low, which correspond to severe sepsis. I know that this audience is well familiar with the definitions of sepsis. One thing that I will note is at Congress on Monday, there will actually be new definitions for sepsis that are presented, so keep your eyes peeled for that. The current definition, I know you're well familiar with systemic inflammatory response secondary to infection, with severe sepsis having concomitant end organ dysfunction, and in our patient's case, the patient had hypoperfusion as well as hematologic dysfunction. Septic shock is most commonly described in the literature as hypotension that's unresponsive to a fluid challenge. Notice here that the definition relies on a MAP less than 70, which is different than your resuscitation parameter, which your target is a MAP above 65. And as we mentioned before, again, shock is best described as inadequate tissue perfusion. When we think about treating these patients with sepsis, I know you're all well familiar with the Surviving Sepsis Campaign guidelines, and that's what the majority of these recommendations will be centered around. The guidelines do recommend to administer antimicrobials within the first hour of recognition of severe sepsis and septic shock, to give one or more drugs to target the likely pathogens, and to pursue source control as appropriate within the first 12 hours. I know you're probably familiar with this large retrospective study that looked at the effect of giving adequate, effective empiric antibiotics and its effect on survival. The study showed that giving antibiotics early for these patients with hypotension led to higher survival incidence. And at least in the first 6 hours, these authors found that every hour that antimicrobials were delayed after the onset of hypotension was associated with a decrease in hospital survival of 7.6%. Again, strong evidence to support, at least in patients with septic shock, giving early effective antimicrobials. There's a lot of controversy about using combination antimicrobials, and I feel like this is an area that we should spend a bit of time. There was a study published in 2012 of patients with severe sepsis that randomized patients to meropenem alone or meropenem plus moxifloxacin. The primary outcome for effectiveness was a change in SOFA, and this study actually did not find that difference between these patients. The one critique that I will mention for this study, though, is that moxifloxacin may not have been the right choice to add on as combination therapy in these patients, as well as the vast predominant presentation for these patients was a community-acquired infection, such that meropenem is probably adequate for most of those patients. When looking a little bit further into large meta-analyses and meta-regressions, there was a study that was published in 2010 that combined data from 50 studies of patients with sepsis and actually found that there was a mortality benefit in patients with septic shock who received combination antimicrobial therapy. And this was also supported on their meta-regression, suggesting that the higher the patient's odds for death, the more benefit the patient would receive from combination therapy. And so I think that that's probably the the patient population that it makes the most sense to give combination antimicrobials to. And the rationale here is that you want to have at least one drug that is effective against the pathogen that you have. I know there's a lot of controversy out there about synergy and other pieces of combination therapy, but this is the one piece that has been shown at least most effectively in the literature. Most of the time, this is just empiric therapy, not definitive therapy. There isn't great evidence to use combination therapy for definitive therapy unless you're talking about rare scenarios such as carbapenem-resistant Enterobacteriaceae infections. We'll talk about resuscitation a little bit, again, by going through a case. So this patient was presented to the medical ICU, received 30 milliliters per kilo of LR, started on vasopressors to maintain a blood pressure above 65, MAP. You as a MICU pharmacist recommend initiating quantitative resuscitation for the patient. So according to the Surviving Sepsis campaign, which resuscitation goals must be used? Unlike Dr. Lott, I'm not privy to popular music, so I have a daughter who I can tell you all the Dora songs, don't worry. And so here, the most popular response was the last one, must include assessments for fluid status and tissue perfusion. And I think that's the best answer now. Those of you who answered with an answer related to CVP and SCVO2, we'll talk about some updated guidelines that you might not be familiar with. The initial resuscitation of sepsis does involve quantitative resuscitation with, at first, starting with a 30 ml per kilo bolus. The guidelines that were published in 2013 discuss using CVP, MAP, urine output, and SCVO2, but these actually have been eliminated from the guidelines. There was an update that was published, at least online, by Surviving Sepsis campaign almost a year ago now, in April of 2015. And in those guidelines, they actually discuss these new studies for quantitative resuscitation, which I know you're familiar with. I've only presented the meta-analysis here. And these new studies, the PROCESS, ARISE, and PROMISE studies, did not find a mortality benefit with early goal-directed therapy by the Rivers method. And so using that method has not been associated in large studies with improved outcomes for patients. And so strictly abiding by those resuscitation parameters is probably not necessary in practice. And so because of that, the Surviving Sepsis campaign has revised their bundle, and they actually break it down into a 3-hour and 6-hour component. And here are those pieces. The first is that you should measure a lactate. You should draw blood cultures before giving antibiotics, and then give antibiotics within 3 hours. The earlier, the better. For patients who have hypotension or hyperlactatemia, they should receive 30 mLs per kilo of crystalloids. For the 6-hour component, there are again 3 pieces. If your patient's hypotensive, to start vasopressors. If your patient is hypotensive after giving the fluid challenge, to use an assessment of fluid status as well as tissue perfusion and document those findings. And lastly, to remeasure the lactate if the initial lactate is elevated. Those of you involved in quality measures at your site will recognize these as a CMS quality measure that has been instituted, and they actually correspond directly with what Surviving Sepsis has recommended. When talking a little bit further about documenting that fluid status and tissue perfusion, there are all kinds of pieces. There are components of this. Essentially, you need 2 pieces. One is either a focused exam that's repeated after fluid resuscitation and documented by a provider, or 2 of the following that can include CVP and SCVO2, but don't have to include CVP and SCVO2. I know at our site, this has led to a lot of challenges with corresponding to the measure, but I do think that it does make sense in a lot of ways for patient care. Some other goals that we'll talk about just briefly will be whether you should target a MAP of around 65 or an even higher MAP. This is a study that actually randomized patients to a MAP of 65 to 70 versus 80 to 85. And you can see here with the Kaplan-Meier curves, there was no difference in outcomes in all patients with these 2 strategies, whether at 28 or 90 days. One piece that I will point out, though, is patients who had baseline hypertension who were randomized to the higher MAP target actually had a lower need for renal renal replacement therapy. And so it goes to show that you need to target your resuscitation and endpoints to individual patients. Some patients may have shifting of their zone of autoregulation, and you may need to target higher MAPs in those patients to improve end organ perfusion. There also was a study of patients with septic shock asking what hemoglobin target we should use, whether it be 7 or 9 as a transfusion trigger. Those who were randomized to the lower target had less transfusions per patient. More patients didn't get any transfusion, but there was no difference in 90-day mortality or ischemic events. And so within septic shock, a hemoglobin target of transfusion of 7 is probably adequate. Moving on to fluids, we'll start by a self-assessment question. This is a 56-year-old male who's admitted to the ED with CAP. Antibiotics are given. He's hypotensive. Hyperlactatemia is present, and the patient's given 1.5 liters of sodium chloride. Afterwards, his blood pressure is still low with a lactate of 4.6. Urine output is 30 mLs per hour. CVP is 6, SCVO2 63, hemoglobin at 9.2. So which therapy would be best for the patient now? Okay, the most popular response here is sodium chloride. I think that's the best answer here. This patient hasn't received 30 mLs per kilo of fluid resuscitation, so giving more fluids is most appropriate here. Starting phenylephrine as a first-line vasopressor is probably not the best choice. If norepinephrine had been a choice here, I think I would have struggled with what the right answer would have been. But I think of the answers here, I think giving more fluid makes the most sense. Which fluid to pick? Again, we've talked about the SAFE study a bit. But usually crystalloids are the initial fluid of choice. We shouldn't use hydroxyethyl starches. Albumin is only recommended when you've given substantial volumes of crystalloids. We should use a fluid challenge technique to get to that 30 mLs per kilo of crystalloids. We'll first start off with the bad. This was a study in just patients with severe sepsis and septic shock called the 6S study, where patients were randomized to starch versus Ringer's acetate. In this study, there was actually higher mortality with starches and higher need for renal replacement therapy, and thus the strong recommendation to not use starches in patients with septic shock. Again, back to the SAFE study, I know you know that overall there was no difference in mortality with albumin. In this subgroup analysis, in patients with severe sepsis has received a lot of recognition. Notice that the confidence interval does overlap 1 here, and so just on nominal analysis, there was no statistical benefit with albumin in patients with severe sepsis. But these authors went on and actually did a meta-analysis of crystalloids versus albumin for patients with sepsis. They only included prospective randomized studies of patients with sepsis and actually found in this conglomerating nearly 2,000 patients, those who were allocated to albumin actually had a lower mortality rate. And you can see the odds ratio here and statistical significance. So these authors actually suggest that albumin should be the resuscitation fluid of choice in patients with sepsis. I think there's a lot of controversy on this still. I think for a lot of pharmacists in practice, we thought the door was closed on this answer, and I would argue that the door is still open. There are large randomized studies that are ongoing trying to address this question, and I would argue that this meta-analysis also has flaws that I don't think that we can take the conclusions fully hook, line, and sinker, so to speak. When I think about the Albio study, though, that I'm sure a lot of you are familiar with, I separated in my mind what the intent was. In the Albio study, these authors were not actually using albumin for resuscitation. They were using albumin for albumin replacement. And so in this study, the patients had severe sepsis and septic shock, were first resuscitated, and then randomized to 25%, in this case, 20% albumin for albumin replacement. They found that the patients who were randomized to albumin actually had a lot of benefits. They had a lower net fluid volume, lower heart rate, lower MAP, and actually improved time to achieving MAP goals. although this didn't translate to a mortality benefit in most patients. Some of you may be familiar with the subgroup analysis in septic shock. Again, I think that's controversial. They used a subgroup analysis of a secondary endpoint and found a benefit. I don't think that this is ready for prime time yet, but again, another suggestion that albumin may play a role even in albumin replacement in patients with sepsis. Moving on to vasopressors. This is a case of a 55-year-old male who was admitted to the MICU with urosepsis, history of heart failure. The patient's hypotensive, tachycardic, and you can see the rest of the vitals there. So which of the following is most appropriate to initiate for the patient? My friends in the front are telling me who the artist is because I have no clue. So, yeah, the majority of you picked norepinephrine as the first-line agent. I think that's the best answer here. Those of you that were thinking dobutamine or epinephrine were probably looking at the heart failure piece. Recognize here that the patient has an SCVO2 that corresponds with adequate oxygen delivery, and so giving an inotrope for this patient probably isn't necessary at this point. It's probably best to start with the vasopressor, and norepinephrine is recommended as the first-line agent for these patients. The Surviving Sepsis campaign does recommend epinephrine that may be added to or substituted for norepinephrine when an additional agent is needed, and suggests that vasopressin can be added to either raise the blood pressure or lower norepi dose. What's challenging, though, is to know which order we should do these things in practice. I know at our site we don't use a lot of epinephrine, we use a lot more vasopressin. I think that it makes a lot of sense to look at the patient's parameters and decide which agent is best for the patient based upon what the pathophysiology is showing you. The guidelines strongly recommend against dopamine, except for some few scenarios, specifically a patient with low risk for arrhythmias. I don't know how to predict that, but that's what they say. They say don't use dopamine for renal protection, and phenylephrine is not recommended except for certain scenarios. The first of which is when your patient has a serious arrhythmia on norepinephrine, or in a scenario where you have salvage therapy where your cardiac output is known to be high with MAP persistently low, or when you're adding it to other vasopressors, including vasopressin. When looking just at the septic shock patients, this is the authors from the SOAP2 study that pulled out septic shock and actually did a meta-analysis. In this meta-analysis, patients allocated to dopamine had a higher mortality rate at 28 days, and this was statistically significant. And this is part of what drove Surviving Sepsis to strongly recommend using norepi first line. Epinephrine for septic shock was studied in the CATS study, not to be confused with the CAT study, which also is with epinephrine. This is a study where patients with septic shock randomized to norepi plus or minus dobutamine versus epinephrine. And you can see here that there was no difference in mortality, with even a suggestion that there were more vasopressor-free days in the norepi plus dobutamine group. What I'll caution you about saying epinephrine is okay for the masses is looking at some of these adverse effects. In the epinephrine group, there was a lower arterial pH on the first 4 days of the trial, as well as a higher lactate. And so I would caution just saying epi may make sense in some scenarios, but I'm not quite sure that I would use it routinely for second-line agent. You're probably familiar with the VAST study as well, which looked at vasopressin for septic shock. Wish I had more time to talk about my favorite drug, but I don't. In this study, there was no difference in 28 or 90-day mortality. But what was beneficial with vasopressin were lower norepi infusion rates and a suggestion that there may have been a benefit in less severe shock, but that I think still bears to be concluded further and with further studies. When talking about inotropes, specifically dobutamine, dobutamine does have a role in septic shock. Not all of the patients develop hyperdynamic shock states that we expect. Some of these patients may have myocardial dysfunction where dobutamine makes sense, or if you have a patient who remains hypoperfused despite volume and vasopressors, if you can't get the blood pressure up, dobutamine may be entertained. What's key, though, here is that we shouldn't use a dose above 20 mics per kilo per minute, according to the guidelines. I'll wrap up by talking about corticosteroids by starting with a case. This is a patient who was admitted to the SICU with aspiration pneumonia. The patient's intubated, resuscitated with fluid, started on 8 mics of norepi. The blood pressure is here. CVP is 14, SCVO2 is 55. So which is the best choice regarding the patient's steroids therapy? Okay, it looks like the majority of you said no steroids are necessary right now. I know if this patient was in our surgical ICU, they would be started on steroids. But I think that the best choice here is to not recommend steroids. This patient has been resuscitated adequately and is on low levels of vasopressors, probably will not benefit from corticosteroids. The guidelines do recommend that if you're going to start steroids, to give a dose of hydrocortisone of 200 milligrams per day for patients who are poorly responsive to fluids and pressors. I don't know exactly what that means. I think that's hard to implement in practice, but we'll talk about a little bit of evidence. The guidelines further recommend that the ACTH stim test should not be utilized to identify patients who will benefit from corticosteroids. And if your patient does survive their severe shock episode, you should taper off hydrocortisone when vasopressors are no longer required. Steroids have been evaluated in a lot of large randomized trials, and in fact 4 meta-analyses that I'm aware of. This is the meta-analysis that was used by the Surviving Sepsis Campaign to develop their recommendation. Here they looked at the mortality broken down by placebo mortality in the studies. And so patients with a placebo mortality that was less than 50% did not have a mortality benefit with steroids. But in patients with a placebo mortality above 60%, so again, more severe shock patients, there was suggestion that steroids may have a benefit, but notice as well that this relative risk also overlaps 1 with the confidence interval. And so again, still very controversial about which patients will actually respond to corticosteroids. If you're entertaining steroids in your patients and you're contemplating, I want a mortality benefit, it probably makes the most sense for the most sick patients. And your less sick patients, you probably won't have a mortality benefit with steroids, although you may have other benefits such as lower vasopressor requirements. So we finally made it through all of the sepsis and shock pieces. Just to keep us on time, I'll conclude here, and Dr. Latt and I will be available in the back if you have any questions.